Good morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at the St. Michael's Hospital Academic Family Health Team and also the Vice Chair for Quality and Innovation at the Department of Family Community Medicine at the University of Toronto. I'm really pleased to co-host these sessions with our colleagues from the Ontario College of Family Physicians, and I'm going to turn it over to Dr. Liz Muggah, the president of the OCFP, to introduce the session. Liz?
Thank you, Tara. Good morning, everyone. We are absolutely delighted to be joining you again today, and we've got a great panel for you. Dr. Peter Juni and Dr. Allison McGeer are here to share their thoughts on everything from transmission to mixing and matching doses and variants. So really looking forward to this. And if we just go to the next slide, this session is accredited for Main Pro credits. So you can see the details there. You'll get an email about that after the session is over. Next slide. And I should mention that David Kaplan and I are also here as the regular panelists. So looking forward to this session. So the land acknowledgement, I will just read now. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and the DFCM recognize that the many injustices experienced by the Indigenous people, it's hard to read this today, of what we now call Canada, continue to affect their health and well-being. The OCFP and the DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. So really important that we commit ourselves to the actions that are in the Truth and Reconciliation Commission. And I can tell you that the OCFP has definitely, in light of what has happened with the children that in Kamloops, to our responsibilities under the TRC. I will pass to Tara now, because I think we have some additional reflections on that.
Next slide. Yeah, I mean, I think for me, the land acknowledgement, for so many of us, land acknowledgement has taken on a whole different meaning after the events of this past week. I know I have been thinking about this daily, multiple times a day, and our own responsibilities for moving forward. And I know there's so much out there to read and process, and I wanted to share with you a colleague from one of my article from one of my colleagues, Dr. Suzanne Schusch, who shares a very personal story of her family and how her own grandfather lost 7 of his 9 siblings in residential schools. A completely heartbreaking story, and also a poignant call to action. Next slide. I think it is important to remember how can we translate this? I mean, we have a time to mourn now, and how can we translate our sadness into action? And I'm just sharing with you here, you know, the Sannyas Indigenous Cultural Safety Training, because one of the very important calls from the Truth and Reconciliation Commission is for us as healthcare providers to study how we can make our environment more culturally safe. And this is an accredited course, $300. I did it 2 years ago and would highly recommend it. We're also sharing here some resources for us to support our patients who, this is extremely triggering for so many of our Indigenous patients, for all of them. And there's 2 resources here that may be of help. Next slide. I'm particularly grateful to gather with all of you, today with everything going on. I find these communities of practice increasingly to be a place of support for all of us during this difficult time. And a reminder that all of our sessions are available as a recording on the website within a couple of days. Next slide. If you have any suggestions for upcoming speakers, please do let us know. Our planning committee looks through the evaluations that we're going to be sending at the end of the session and develops the sessions based on your feedback. Next slide. I'm really delighted to welcome today our panelists. And they're going to introduce themselves one at a time, but I do think the conversation today is particularly timely for those of you who are print subscribers of the Globe and Mail like myself. You'll see that Dr. Peter Juni was actually quoted on the front page today on an article about transmission of the Delta variant and the need for increased vaccination in hotspots. So next slide, I'm going to let Peter introduce himself. Oh, Olivia, the next slide, the next slide with the disclosures. Peter, you can go ahead and introduce yourself. Thank you.
Yes, so I'm a general internist and epidemiologist from St. Mike's and U of T. I'm not sure how much you want to know about me, Tara, or whether I shall just disclose my relationships.
Yes, please do that.
Just those, yeah, okay, good. So I'm having a grant together with Allison McGeer on a trial that became obsolete, meanwhile funded by Apili Therapeutics on an antiviral agent, and I'm having have received to the institution honoraria from Amgen and Fresenius related to cardiovascular trials, and I'm sitting on steering committees, executive committees, unpaid, for trials funded by Apili, Abbott Vascular, and Terumo. That's all.
Thank you, Peter. And Peter, did you tell us just your positions and stuff? You're the chair, of course, of the Ontario.
No, of course I can. Sorry, I didn't get that. What do you want to know? So basically, I'm typically in my day job, which I've given up like centuries ago, it feels. I'm the director of the Applied Health Research Center at St. Mike's. So I'm basically helping clinician scientists to resolve their methodological crosswords, build trials, meta-analysis, advanced statistical analyses, etc. And last year in June, I was seconded, asked to take over as scientific director of Ontario's COVID-19 Science Advisory Table. And that's basically what I do now, nearly, I felt 24/7, basically, with great colleagues such as Allison.
Thanks, Peter. Allison, can you introduce yourself and speak to your conflict?
Yep, thanks. So I'm Allison McGeer. I'm an infectious disease physician at Sinai Health System, who was retiring before COVID came, but retirement is not working, as you may have noticed. As you can see from this list, I do a lot of work with vaccine companies. So I have grants and research support from a number of them. And I'm one of the approximately 120 people who puts in small contributions to the Ontario Science Table.
David?
Hi, everyone. I'm David Kaplan. I'm a family doctor here in North Toronto and the Chief of Clinical Quality at Ontario Health. I don't have any grants or research support currently or in the last number of years, and I do receive salary support from Ontario Health and an honoraria for these sessions from the OCFP. Good morning, everyone.
Next slide, Liz.
Hi, as I said, I'm Liz Muggah. I'm a family doctor in Ottawa and the president of the Ontario College right now, and I receive a stipend for my role as president.
Yes, and I've already introduced myself, and I've listed here some of the grants and salary support that I receive. And the only one from a for-profit company is Gilead Sciences for our grant on hepatitis C. Next slide. So welcome to all of you from different parts of Ontario. Today we're going to be talking about many things you asked about. Of course, we're going to talk about transmission and the latest on transmission. Peter's going to run us through that. We're going to be talking about the latest on the new variant Delta, the second, how we can guide our patients on the second dose related to AstraZeneca, and the risk of myocarditis and more. So lots of questions that you put into your registration fields when you signed on for this webinar. Next slide. Clearly, most of you know that we like to have our questions in the Q&A. We already have 22 questions there, and amazingly, 9 of them have already been answered by our panelists. So our panelists are already working hard. So before you put in a question, just remember, please review the answered questions first and take a look at the opened questions. If the question is there that you want to ask, please just give it a thumbs up, because I will be prioritizing the ones with the most thumbs up. Those are the ones that we are going to be answering live and prioritizing answering. And then as we usually do, we will provide a summary of the Q&A after the webinar for both posted online and sent to you. Next slide. So without further ado, I'm going to turn it over to Peter to start us off. I think we'd invited Peter initially, and Olivia, you can get Peter's slide started. But we've invited Peter initially because you know, there's been a lot of discussion about the changing nature of what we know about COVID-19 transmission, and we wanted to better understand that and understand the implications for our office practices. And Peter's going to take us through some of that evidence. Olivia, do you have Peter's slide?
Thanks. So yes, next slide. What is important just to realize just first, just to you know, think about that once more. What is giving SARS-CoV-2 an edge over SARS in 2003? You know, Allison knows that a lot better than I do. And what made this virus, unfortunately for all of us, so successful? And this is really important just to think about that quickly together. The reason for that is that SARS-CoV-2 is transmitted in many situations either before people become symptomatic or while they stay asymptomatic. That's probably a minority of cases, people who stay completely asymptomatic, but still it happens. And this distinguishes this thing from many other viruses. And it also means that what you're seeing, if you look at viral loads over time and at infectiousness over time, that the challenges happen very early on in the community or in your practice, and the challenges will decrease regarding transmission once people are actually going down the road of becoming symptomatic, more severely ill, being hospitalized, ending up on an ICU, etc. That's the paradox here. We should protect ourselves against transmission when we don't have a clue that there's transmission happening. And once people are in hospitals, things are quite a bit different, and it is relatively safe to assume that transmissibility with people who actually became hospitalized or were hospitalized because of COVID-19 is considerably less than what happened before. Only before, nobody has a clue that a patient actually will become a COVID-19 patient. That's the real issue. So when we're discussing what we're discussing now, this holds for you guys, and it doesn't hold for our colleagues who work as intensive care physicians or general internists in hospitals. That's a different cup of coffee. Next slide. And you know, this slide here that refers to a paper from 2019 shows you that the discussions we're about to have are actually, you know, old discussions that do not only hold for SARS-CoV-2 and COVID-19, they hold just for other respiratory viruses as well. And that's really important to realize. Next slide. And that's then basically, of course, the 101. How could respiratory viruses in general and SARS-CoV-2 in particular be transmitted? Direct, that's a no-brainer. Indirect contact or fomites, droplets or aerosols. The point is, and that's again important to understand, next, that only, oops, there's something, if you go back one slide, it doesn't matter. Can you? It doesn't matter. But what is important here, just to realize, is that the indirect contacts are having a special position, because there you actually are able to disentangle the relevance of surfaces and of indirect transmission, whereas for direct contact, droplets and aerosols, it's always sort of the same exposition, and nobody will be able to distinguish if you just are having direct contact with people. This means you're also exposed to small particles and large droplets, and nobody will ever be able, just to distinguish, is it the mere fact that I touch somebody, which is probably unlikely, to be the reason for transmission in many situations? Or is it that I was either exposed to large droplets, smaller droplets, or to aerosols? And that's important just to realize. Next slide. So if we first go to indirect contact, next, then this paper here is a key that was published relatively early on during the pandemic by a Dutch group, Van Doremalen and colleagues. Next. And what you basically see that on smooth surfaces, and it's actually irrespective nearly of the type of surface, except for copper, on smooth surfaces, both SARS-CoV-1 that caused SARS and SARS-CoV-2 just stay on the surface forever and ever and ever. So if you have frequently touched surfaces, you might then be just tempted to feel threatened by these surfaces from an IPAC perspective, of course. And it's important just to understand what we learned during the last few months about the relevance of that. Next slide. The fact that these viruses stick on surfaces is, again, nothing extraordinary. If you look at that again, that's a BMC Infectious Diseases paper from 2006, you see that viruses just tend to stick on surfaces, and they then can indeed be transmitted through your fingertips to your eyes or to your mouth, etc. That's all possible, and we've known that before. So again, SARS-CoV-2 is nothing extraordinary there. Next slide. But what is important here to realize is that when you look at surfaces in modeling studies and just try to factor in everything we know about frequencies, about transmission efficiencies, etc., and about evidence that is predominantly generated from observational analysis. We're in the middle of a pandemic, and we don't have much out there that is randomized evidence, which keeps confusing some of my colleagues in evidence-based medicine sometimes. What we see is that it is hand disinfection that probably makes a difference, and not disinfection of surfaces. And that's really important just to realize the evidence that we're having based on observational data and modeling exercises just points towards, yes, make hand disinfectants available, but probably regular cleaning is just okay. We might just want to stop to, continuously disinfect everything after somebody sat on a chair or whatever. It's the hand disinfection part that is much more important. There is an exception to that potentially, and again, it's only observational evidence. If you have SARS-CoV-2 infections in your household, it could be that disinfecting frequently touched surfaces could make a difference, but this is a really high prevalence situation with the risk of secondary attack in a situation in a household, potentially being as high as 30, 40, or 50%. No, that's the situation there. So for everything else we know, forget about it. What probably makes a difference is hand disinfection. Next slide. So if you now come to droplets and aerosols, next, what you first just need to realize is that there is no such thing as a division between droplets and aerosols. We're always talking about the spectrum of particles. And how does this look even if we cough? Next slide. That's the situation here, in an experimental setting that allows you to understand the size of particles. Next slide. And what you see is that next, I'm not sure whether that works now with the animations or so, we'll find out. Is something happening? Not really, yes, it does. And then next slide. Here, the first arrow to the left, that's where most of the particles actually are happening, even when you cough. You know, that's coughing that results in you producing large droplets. And look at the numbers of droplets that are having a size of at least 50 and perhaps 100 micrometers. It's not visible on this slide. Most of what we generate, if you go back, please, yeah, most of what we generate basically is small particles below 1 micrometer. And that's again important to realize. And obviously, if we don't cough and if we don't sneeze, then we nearly exclusively just generate what is small, what is below 1 micrometer. This doesn't change the spectrum. It's just that the large droplets, unless I speak loudly and have a TH, you know, as a Swiss in what I say, I won't generate much of large droplets anyway. Next slide. And what you see here now is a distinction between an aerosol, 0.5 micrometers to the left, and a droplet that would be considered a large droplet of 50 micrometers to the right. And it's quite obvious if you just look at the difference in dimension, these buggers will behave differently from a physics point of view. No, what you see to the left stays in the air for a longer time, whereas what you see to the right, until it dries out in dry air, will just drop to the floor immediately. And that's basically what distinguishes, even though there is no spectrum, smaller from larger particles. And just remember, the smaller ones to the left are much, much, much more frequent. Next slide. When we now go to an understanding of speech-generated oral fluids, next slide, as you see here, then when you just speak something such as stay healthy, then what you're generating, if you don't have a mask in front of your face at 1 meter distance or closer, that's what you're generating here that can be visually detected. And then next slide, if you again say stay healthy, but you have a damp washcloth in front of your mouth, nearly all of that disappears. And it's not only the large, but also smallish particles that could be detected in this experimental setup that was published in the New England Journal that you can actually decrease. And we'll see later, you can decrease much more with conventional masks or washcloth or whatever we're actually using. We don't need N95 all the time. That's again really important to notice. Next slide. When we then look into, again, what I was referring to before, that we're talking about the spectrum, a few large droplets, but most of what we're seeing is much, much smaller. Next slide. Then if we sneeze, for example, what we just see is a gas cloud evolving over time. And first, what you see is, you know, this disgusting set of large droplets predominantly, but you already see on the slide, there's also a lot of small stuff that we just expose. And now when we go on, exactly, you start to see what's happening. Probably the animation won't work, but you see still the pattern. Next, please. It sort of works, great, okay. And what you see is that this gas cloud actually makes it over time to relatively far, 7 to 8 meters. And in the end, when you sneeze without a mask, what you're distributing after, you know, 30 to 45 to 60 seconds is something that goes relatively far. Not just, you know, our 2 meters. The 2 meters hold very nicely for droplets, large droplets, 50 micrometers or more. But when you think about the gas clouds, this all just goes much further. That's important, again, to realize that's one of the rationales for masks, of course. Next slide. When we then just again go into seasonal influenza, just making the point here, this is not extraordinary what we're discussing. Same sort of discussions could be held by people like Allison McGeer for influenza. Next slide. then what we're seeing is that it's possible to detect viral material. This is not viable virus, but don't fall into the trap that you say, oh, never viable virus detected or so, or cultivated. Therefore, we can just distinguish that everything is just happening in the nasopharyngeal swab where this viable virus was cultivated, and what we see just with RNA copies is not relevant because it's not viable virus anymore. Don't mix up absence of evidence with evidence of absence of viable virus in coarse or fine particles. The point here is that with exception of the nasopharyngeal swab, obviously, what you see is that coarse and fine particles actually just sort of have the same amount of RNA copies that could be relevant, large or small droplets or aerosols. Next slide, please. And these aerosols, if you just have a fixed cube of 1 meter of air and just keep this fixed cube of 1 meter of air just maintained without ventilation, these aerosols just stay with detection of virus, as you see again in the Van Doremalen study that I showed you before, published in the New England Journal of Medicine. Next slide. Now, that's a story about masks. Let's forget about prolonged discussions when an N95 is needed or when not. And let's remember, this virus, as many other viruses, will become effective and result in infection if the cumulative exposure to it is large enough. This is a matter of what you get immediately, of course, and the length of exposure that you're having. And everything counts that you can do against this dose that accumulates over time. Next slide. In this very simple setup here, again, that was done early in the course, they tried just to look into the small aerosols and just ask themselves, okay, am I able to decrease aerosol dose? Next slide. And what you see here, it doesn't really matter. I just flip through the slide since I used quite a bit of time, is that whatever you do, if you use an FFP2 that corresponds to an N95 or just a T-cloth or a surgical mask, you have a certain effectiveness against viruses probably, and small particles for sure. Next slide. And it just give you different papers. Next slide here. You can do all sorts of things, and all of what you're seeing here, as long as it's well fitted, will help to decrease the load of particles. Next slide. This holds particularly well for stuff like what you see to the bottom right corner here in this paper by Clapp et al. In JAMA Internal Medicine. You decrease the amount of aerosols if you use masks or contraptions that fit well. Next slide. Go on, just beyond that. Next slide. This also holds for double masking that actually works better than single masks, probably not predominantly because of the filtration effect, but just because of double masks fitting better than single masks if you do it smartly. So it's basically a combination of filtration and good fit of a double mask that helps, with a medical mask inside and a cloth mask outside, typically what really works well. Next slide. And that's a summary, basically. These masks, whatever you take, what they just result in is two things, obviously. It protects yourself and it protects others. And if everybody just wears masks, especially if the ventilation setting is reasonable, it just results in a relevant decrease in the amount of virus that can be breathed in. And that's what is important here. It's not about the absolutes that you achieve with an N95. It's just about decreasing doses. Next slide. And this here just gives you once more just a hunch. This is a paper by Trisha Greenhalgh with David Fisman being one of the co-authors, that Aerosols probably will play a role in the community setting for transmission, and therefore it makes sense just to take into account that masking is one aspect, and of course ventilation is the other aspect that you just will need to consider. Next slide. Now, just quickly 2 minutes regarding Delta, that's B16172, that is currently just making headlines because it actually took hold in Ontario. Next. That's important to realize. The situation we're in now with Delta is not the same situation that we were in February with B117 that is now called Alpha. What you see here is that the variants that don't have the N501Y mutations, that's what you see here in orange on the slide, are on a downhill since very early in a second and then a third wave. And what you then see is basically this downhill slope comes to a stop and it starts to be a horizontal line in May. That's in orange. And what you see, if you go back, please, what you see here in blue is the behavior of B117 already before February. It was in growth and it continued to be in growth and it continued to be in growth, etc., until we really reacted and started to have proper public health measures, which came relatively late in April, as we know. And that's the point here. The situation we're in now is not the situation of the Alpha or B117 variant. It's much more benign. Why? Because we have already vaccinated a lot of people and we're much more careful with our public health measures. Next slide. What is important to realize is, and that's corresponding to the article that Tara was referring to in the Globe and Mail, is that this thing took hold in the province already probably in March, and we just didn't know. And what we know is that Brampton, unfortunately, again for Brampton, where all the work is getting done on behalf of all the Canadians, Brampton again has about 4 weeks an edge in terms of the course of the Delta variant. It has taken over among N501 negative variants already as early as 15th of April, and Brampton and Peel now have already roughly 25 or 30% of the variants out there being Delta variants. Next slide. This means basically that we have everything under control. That's what you see to the left still with B117, but we just linger around 1 with our effective reproduction number now for in the province for the Delta variants, and that's the challenge when we start to open up. The effective reproduction number of 1, meaning a stable situation, will start to raise if we start to open up more. Next slide. And the challenge is related to what you see on this slide. If the basic reproduction number started to be at roughly 2 with the wild type in Wuhan, it started to up its game with B117 coming from the UK with an increase in transmissibility of about 1.5. And compared with B117, the Alpha variant, Delta now, B1617, again has 1.5 times increase in transmissibility, meaning your basic reproduction number might be as high as 5. Next slide. One additional challenge that Allison will talk about is coming from here. The vaccine effectiveness is, after 1 dose, excellent against Alpha, but after 1 dose, it's limited against the Delta variant, as you see here in these numbers. What does it mean? A first dose against Alpha is more effective than the step from a first to a second dose against Alpha. As you see it, this step from 70 to 90% against B117 only adds effectiveness of 33%. Against Delta in hotspots, the situation is different. The step from 40% effectiveness after the first dose to 90% effectiveness after the second dose means that the added effectiveness after the second dose outweighs the effectiveness that you get from a jump from a no dose to first dose. This means in hotspots where we have a lot of the Delta variants, it makes sense to pivot from first doses only to a combination of first dose and second dose vaccination because you get more bang for the buck. Last slide. Conclusions. We have 4 plausible routes of transmission, but it's important to acknowledge that in your setting in the community, aerosol transmission is a relevant route. This may be much different in hospitals. Remember, people in hospitals typically don't transmit that much anymore. It's happening before the hospitals. Indirect contact may be a relevant route, especially in the community, but hand hygiene is dominating there. And Delta will become dominant in Ontario, but this time we can vaccinate ourselves out of a 4th wave. The basic reproduction number of 5 indicates that unvaccinated people in the future will have a high probability to get infected. Thank you.
Peter, can I ask you a follow-up question directly on one of your conclusions?
Yes.
So a lot of family physicians have been working in hospitals, not for admitted patients, though some have, but in our assessment centers when patients' viral loads could be higher. Can you speak to that versus the patient who's in a hospital who's admitted? Because you made this sort of distinction between the inpatients may be different by the time they're inpatients, but a lot of us are working in hospital CACs.
Yes. I think that's where patients, together with the pre-symptomatic situation where a lot of transmissions happen, that's where basically patients are most infections. No, that's the point there. And what you will want to achieve in these situations is optimal ventilation and good masking, and it depends on the availability of masks how far you want to go.
Thanks, Peter. Allison, it seems you wanted to jump in. I want to get to a couple of questions from the audience as well.
I just wanted to say that there are as yet unpublished data from a number of the assessment centers in Toronto that I know about, Michael Garron, North York, Unity Health, and there has not been significant transmission. So whatever ventilation there is in those assessment centers is clearly enough at the moment. I think piece of the distinction is, even though our ventilation may be less than perfect in hospitals, it still appears to be sufficient to control aerosol transmission. That may be very different in some nursing homes and schools and gyms, for that matter, that just don't have any ventilation at all.
It's really important just to realize, these pragmatic solutions of masking plus ventilation, as good as it gets in many settings, it's enough. Remember, this is dose dependent. It's not that you just get infected by a single virus particle, not at all.
Thanks, Peter. So I think, related to what you've been talking about, Alan Grill asks, at what point do you think we can bring patients into our office who are fully vaccinated against COVID without screening them at the door or worrying about sending them for a COVID test if they have any kind of respiratory symptoms? It'll be a game changer for ramping up.
Are you talking about fully vaccinated people now, correct?
Correct.
I think, and Allison will need to chip in there as well. The moment when we, start to see numbers decreasing even more, and we have full protection through with 2 doses of the vaccine, this means that what you see out there, the pretest probability, which will already be low, will be reduced by a factor of 20 once you're fully vaccinated. From my perspective, this means that even if somebody actually is symptomatic and the community transmission is low for SARS-CoV-2, that you could consider to stop testing. That would be my personal view, and I would like to hear Allison, who has a lot more experience.
Yeah, I just think we need to wait and see what the Delta variant is going to do, because it's definitely more transmissible, and if and it's not as sensitive to first dose of vaccine. And so I think we need to give it several weeks of, how quickly can we vaccinate our way out of this, which is just really frustrating. But eventually, when we get to where Israel is, okay, 2 doses in, cases down, then we can quit. And I'm like hoping for September. But, I was hoping for June, and then the Delta variant came. And so, I don't want to be promising stuff that we're not going to be able to deliver.
I think the point really is it's 2 doses. It's 2 doses of the vaccine and really low community transmission. Everything else doesn't work with Delta. Sorry.
No, thank you for emphasizing that. So a couple of other questions really directly to your talk, Peter. Kiran, Cameron, and I think Jordana Sachs asked similar questions. Can we stop wiping down our rooms after every patient in office and decrease cleaning to every 2 to 4 hours? Or what is the current recommended interval? And Jordana Sachs asked something similar. Can we stop wiping down the chairs in our vaccine clinics, please?
Allison, I think you need to chip in. I have a slightly different view because I'm not an IPAC physician. From my perspective, based on what I've shown you also, and based just on simple probability calculus, this is much more about hand hygiene and conventional cleaning and stop being neurotic. But this is, from my perspective, something that I don't know, Allison, whether you agree on that.
Yeah, the key, I don't care if you clean surfaces, if you disinfect your hands before you put your hands up to your face and before you touch a patient every time. So environmental cleaning is mostly about compensating for the fact that we're all not very good at hand hygiene, right? So over and over and over again, if your hand hygiene is really good, cleaning is not so important. So yeah, I think you can go down from cleaning between every patient to cleaning on a regular basis. Just make sure you do it, okay? And I don't know what I'm not about to argue. Vaccine clinics are doing an amazing job. Yesterday, we set a record in Ontario, more than 176,000 vaccines given in a day. So I don't want to interfere with anything in vaccine clinics because they're working. So personally, I would be tempted to say we don't have to clean them down every time. When I've been working in a vaccine clinic, I admit to having forgotten occasionally. Yeah, we're probably doing a little more cleaning than we need to be doing.
Okay, thanks to both of you for that practical answer. This is also an answer, I think that's going to, segue your 2 talks maybe perhaps. And I know there are also some really burning questions at the top there that I think Allison is prepared to answer during her talk, which is why we haven't asked them yet. But Layli Petey has asked, as you said, Peter, B1617 or Delta is already prevalent in Peel, Brampton. It's predicted to be dominant in the next 3 to 4 weeks. 1 dose offers some protection. You told us we need 2 doses. Is there anything more in general to help plan strategies around that? Is there anything else that people should be thinking about other than the 2 dose, which you emphasized?
We should encourage people not to travel. That's the point. What we would like to see is this thing being concentrated in the GTA and nowhere else. So one thing is to vaccinate as fast as we can in Peel. This will protect Peel and the province. And the second thing is, let's avoid that people just start to move from the GTA to somewhere else. That's a theory, not a practice, because we don't have a stay-at-home order anymore. But that's what would be important, that we can gain some time. The more time we gain, and remember, in 1 week, we currently do 1.5 million doses. In 10 days, 1.5 million doses roughly. This means even a week will make a hell of a difference.
Thank you, Peter. That's terrific. So, Olivia, I'm going to ask you to bring up Allison's slides. As you're doing that, I'm going to pose a question to Allison that I don't think is on her slides, and I think the rest of the ones actually you've done that quite fast. So, Allison, why don't you go through the slides, and then we'll go through some of the other questions that we haven't answered, but I think you're going to answer a lot of them with the slides that you have prepared.
If I unmute, I'll stop talking to myself. Sorry. Okay. So this is kind of a list of questions in the next few slides. So let's start with second dose AstraZeneca, and second dose AstraZeneca is mostly about people's risk tolerance related to VIT and what the risk is with second dose VIT. And the only data we have on risk with second dose VIT is from the UK, because only the UK that's using AstraZeneca for second dose in high enough quantities to be able to judge. And part of that is about, to some extent, that's about countries not recommending AstraZeneca anymore, but a lot of it is actually about AstraZeneca having some trouble with delivering vaccine to people. So it's kind of a mixed bag. So it's a bit hard to extract the data. What I've tried to do here is show you what's happened to the estimate of VIT after first dose AstraZeneca over time, because the critical issue here is the delay from when you give a vaccine to when VIT comes up and gets recorded in public health registries, because you have to wait for the symptoms to start and then the disease to prevent and then diagnosis to happen and then that diagnosis to be validated and then it to roll up to the federal government in order to get a record. So on the 24th of March, there had been 18 million first doses delivered in the UK. They had 30 VIT cases, and they were quoting a first dose rate of 1 in 624,000, which they said was background rate and not to worry about. A month later, they're up to 200 cases, and it's one dose in 250,000. 2 weeks after that, we're at 1 in 55,000 for people under 50, 1 in 100,000 for people over 50. And the UK moves to not giving doses to people under 40. At the same time, the second dose rate is now quoted at 1 in a million. A month after that, the second dose rate is quoted at 1 in 600,000. So the problem with this assessment is we don't know where that's going to go. You can look at it and say, well, it's kind of promising that in a month it hasn't gone down much from 1 in a million to 1 in 600,000, and maybe it's not going to go much further. Or you can look at the trend in what happened with first dose and say it's going to end up being 1 in 50,000 or 1 in 100,000 if we just wait another month. And the problem to my mind is that we don't have an answer to that. And so I think the best advice you can give to people is it's looking really rare now, but there is a risk that it's going to increase, and you need to take that into consideration. And there's just no easy solution to people making a decision or to counseling people when they're making a decision. It really depends on what your risk tolerance is for risk of COVID, because you can get the AstraZeneca faster, versus the balance of what your risk tolerance is for VIT with a second dose. I do think the numbers are still pretty small. The case fatality rate in Canada is looking smaller than we were expecting it to, which is really nice, but I'm not sure how solid that estimate is, but it's again a really important message that to take seriously people who have potentially compatible symptoms after a dose of AstraZeneca vaccine. Next slide. Okay, so now Peter's already put this slide up, but the reason for putting this slide up is just to be starting to watch for whether there's a difference between mRNA vaccines and AstraZeneca vaccines. You look on the right side, you'll see that against, I'm still stuck on 617, okay? This is Delta virus now, new World Health Organization naming. My son points out to me that in Hollywood, Delta is always the most powerful. So I'm hoping it's gonna stop here, okay, with Delta, because Epsilon doesn't sound like much of a name for a worse virus. So Pfizer 2-dose estimates 81%. That's down from 95 against Wuhan, but still really good. AstraZeneca in their estimate is only 60. Look at the confidence limits. Okay, not good enough data, but it means we really need to be keeping our eyes open to whether second dose AstraZeneca is maybe not going to be quite as good against the Delta variant as Pfizer. The other reason for looking at this slide is this slide tells you why with Delta variant, second doses are so important. Because if you actually look at their point estimates, and again, watch the confidence limits, don't take anything too seriously, the second dose is now more important than the first dose against Delta. Okay, and what that means is we need to get off this giving first dose to everybody, because first dose is the meal and second dose is the cupcake. Okay, now we're talking, I don't know, first dose is half the meal, second dose is the other half of the meal. And we really need to be pushing to move second doses quickly, which we can do because vaccine is coming faster and we're doing better delivering vaccines. Next slide. Okay, so this is just posted yesterday on the UK variants site. The problem with Delta is the same problem we had with Alpha, B117, before. The secondary attack rate is higher in both household and non-household contacts. Good news that the sequential interval doesn't change. At least you're not developing disease faster, not presenting earlier. And just out, the risk of hospitalization in England and Scotland is also higher for Delta as compared to Alpha. So, you know, this is like deja vu with B117, right? More virulent virus, more easily transmissible. Gonna have to get through it. Next slide. Okay. Now, second doses. I think we've worked ourselves into a bit of a tizzy about when to give people second doses. So the background of what we know is that when you get the first dose of any vaccine, antibody levels climb from the first dose for several weeks, okay, usually sort of 6 to 8. When you give a boost, boosting is in general better if it's later rather than earlier. And later is defined as sort of 8 weeks up to 6 months or a year versus 3 or 4 weeks. But there's not very much data because we just haven't cared about it, okay? We invent vaccine schedules for a whole variety of reasons to get people immune. And when it prevents disease, we just say, okay, that's what we're doing, okay? 1, 2, 6 months, 2, 4, 6 months, whatever works, okay? And nobody's ever looked piece by piece over time. So I think it's really important that we not give ourselves a panic attack about this, okay? Second dose, anytime after 4 weeks is okay. 2 doses of Pfizer at a 3-week interval is holding up really nicely in the UK healthcare worker study against Delta variant, okay? So 3 weeks is maybe suboptimal, but it's okay, it's fine. We know now that immunogenicity is better, so we probably want to space it a little bit, okay? But there's no upper limit. Okay. Yesterday, I got a call from somebody who, for complicated reasons, is now 106 days. Okay. So that he's got like 4 days to the 16-week limit. And we tried to book his appointment in Nova Scotia. They said, oh, it's too late. And it's like, okay, just anytime after 8 weeks is fine. No fuss. Okay. Now, next thing is the NACI recommendations on interchangeability. I would have liked them to be a bit more specific about what they're trying to do. What we're trying to do is make sure that people don't get turned away for second doses. Delivering second doses is going to be harder than first doses. You know, people are going to forget, stuff's going to happen in the summer. And the last thing we want is that somebody turns up for a second dose and we say, oh, no, don't have the right vaccine, can't have your second dose now. And so we're still holding on to general practice is you give the same vaccine. But if you don't have the same vaccine, any other vaccine will do. And that's the sense of NACI's recommendation. Okay, we're trying to stick with same vaccine except for first dose AstraZeneca, where you can have a choice about AstraZeneca or mRNA vaccines, but otherwise just get the second dose into people. Okay, and then the next brief thing is just thinking about who we're giving second dose to first now. And I think we're going to see a fair amount of variability in Ontario between health units, because you can argue that you want to get second dose into older adults because they're much more likely to get severe disease and you want to protect them. Or you can argue that you want to get second dose into essential workers who are younger because that prevents transmission. Those are both right, okay? And so it's going to be really hard to choose. And I think, as Peter pointed out, what we really want to do now is see if we can increase vaccination rates in high transmission Delta areas to try to protect the other areas of the province where we don't have as much Delta in the short term. Next slide.
Actually, Allison, before you move on to talking about myocarditis, I just like it's there's a lot of questions and I want to make sure we get to a couple of them. So the most popular question really has been, please comment on mixing AZ and mRNA vaccines and any new studies out to support this. So is there a study saying there's better efficacy with AZ and Pfizer? Somebody heard of studies in Spanish, a Spanish study said that, or is it recommended now to just get the second AZ? So I know you went over the VITT risk in a lot of detail. You've told us, why the rationale for NACI's recommendation, but I guess just, is there effectiveness data around the mRNA?
So no, there's no effectiveness data. There are 3 studies of mixing, and I don't think there's going to be effectiveness data, at least not in the short term. We're going to have, because COVID rates are dropping, effectiveness data is going to take longer to get now. So it's a double-edged sword. It's good that we don't have COVID. It's bad that that means data is going to come more slowly. However, so there's 3 studies of local reactogenicity post mixed dose vaccine. The UK study says that second dose Pfizer after first dose AstraZeneca, the reactogenicity is higher. And I think my slides from a couple of weeks ago are posted where you can see that, I think. There's a German study and a Spanish study now, and both of those studies actually, the German study actually says there's less reactogenicity after second dose Pfizer. The Spanish study is not a direct comparison, but it says that the reactogenicity is not significantly worse than what we've seen with other things. So don't have to worry about reactogenicity mixing from AstraZeneca to Pfizer. There are 2 studies of immunogenicity. You and I can only see the Spanish study's press release, which says that immunogenicity is fine, but NACI has seen that data, and that data suggests, as far as you can translate it, that the immunogenicity of a second dose of Pfizer after a first dose of AstraZeneca is just about the same as you get for a second dose of Pfizer after a first dose of Pfizer. So looks fine. The UK has not yet shared their immunogenicity data with NACI or with anyone I know. So I don't know that absolutely. I've heard secondhand that it's fine. So I really don't think there's any need to worry about mixing doses. From an effectiveness and immunogenicity point of view, there is, I think, at the moment, nothing to pick between second dose AstraZeneca and a dose of mRNA vaccine.
So I want you to figure out myocarditis, but I'm going to ask a couple of questions first, and I'm also going to just make an executive call to go a little late today until 9:05 because there's just so many questions, and I hope Allison is able to stay till then. So I'm going to just, so you've talked about AZ and mRNA. How about within mRNA? So are Moderna and Pfizer equivalent in terms of mixing?
Yeah, so that's what NACI has said this week. If the NACI vaccinologists will always say, stick with what we know, okay? And what we know most is same vaccine. But NACI specifically said this week that if you don't know, or if you don't have the vaccine available, you can interchange mRNA vaccines. That is permission, okay? These are essentially identical vaccines. It's fine to mix them.
Thank you. And I guess the other point that some of my colleagues, Alan Grill and Noah Igers, have been saying is that the slides you presented around, I guess, a different effectiveness around around Delta, speak to cases and not necessarily serious outcomes like hospitalizations or deaths.
Yes, very good point.
And so that's obviously a really important distinction. And I don't know if you want to speak to, I guess at this point we can only have conjecture around the serious outcomes and whether there is a difference.
Yeah. But okay. We do know in general, what we've seen with the observational study for all of these vaccines is that protection against hospitalization is better than protection against just being a case. And that's usually true of vaccines. And so far it seems to be holding up for these vaccines. So the transmission, so if there's a distinction between protection from serious disease, which is good, but we also want to get protection from transmission out of these vaccines, right? So we're selecting for two effects of these vaccines.
So if I just may chip in quickly, don't fall into the trap and now say, leave just first dose vaccination, especially in non-Delta hotspots. You continue to do first doses, as many as you can, but in the Delta hotspots, when you start to have perhaps 20 to 25% of variants being Delta, that's when you really just want to kick in with second doses as well. And also remember, you can only give second doses if people have had a first dose. So keep going as much as you can with first doses as well.
Thank you. So yeah, I mean, so important. We got to keep going with first doses, especially in non-hotspots. Second doses, really in hotspots where Delta is taking off. So Allison, I'm going to ask this question from Carrie Bernard before you talk about myocarditis, because it's been sitting at the top of the pile for a long time, and it's not exactly directly related to what you're saying, but it's important. And I also wanted to let everyone know if they're signing off now at 9, we're going to go till 9:05. We are going to post all of the Q&As as well as obviously the recording, and we will also follow up with some of the more popular Q&As that we didn't get to. We'll ask Dr. McGeer if she can, and Dr. Juni if they can give us some answers to those. So Carrie Bernard asked, on May 6th, the Ministry of Health put out a document saying that people who have had 2 vaccines and then have a high-risk contact do not need to isolate. Then on May 21st, they put out a document on testing and clearance saying that there is no change in routine management of COVID-19 cases or contacts based on their vaccination history. Does this mean no change from the May 6th recommendation? Do they need to isolate or not?
You're asking me to translate ministry speak, which I am not capable of doing, okay? I don't know what the ministry means. I think the answer is that you can expect for the next at least month or two that hospitals and employers and health units will make different decisions because we're in, for 2 reasons. Firstly, we're in this pattern of change, right? And some people change faster than others, and some health units move at different speeds. And so it's just going to be really frustrating. You're going to get different answers to the identical question for the next month or two. And the second reason for worrying about it is that, a piece of the reason you're going to get different questions is because people are going to have different levels of concern about Delta taking over. So if you think it's Delta, you may be more willing to send somebody even after they've had 2 doses of vaccine off because you're just panicking about it. And if you think it's not, then you might not do it. So, even among our IPAC group on calls, people are really struggling with this question, as nobody knows exactly what the right thing to do is. And so I think we're just going to have to live with some variability in it for the next little while.
Thank you. So Alan is saying that he spoke with PHO yesterday and they had a double vax person who's in close contact that was asymptomatic, did not need to self-isolate, but testing was recommended. So it does seem like, I think we're just going to have to see how it plays out with PHU recommendations. So another question that was very related to this is if someone did have 2 doses of AZ, should they have a booster dose of mRNA with the new variants? And is that something that we're going to need to do?
So I think there's a lot of discussion now about when and if we're going to need booster doses, right? If you've had 2 doses of AZ, if you're immunocompromised, if you're 6 months out from, 2 doses of an mRNA vaccine, and we don't know any of that. We do know from the Siren study in the UK that 2 doses of Pfizer is holding up nicely. So I think those people who had 2 doses of an mRNA vaccine don't need to worry about boosters. It's perfectly reasonable to worry about boosters for everything else. But really what we need now is first dose and second dose into everybody. Yeah. And unfortunately, we just don't have data yet on whether, a 3rd dose will work for somebody who's immunocompromised and didn't respond for the first 2 doses, or whether you can get an additional boost in somebody who maybe is okay, but didn't have a great response. All of that, we're just going to have to wait for. And I think we really need to keep our eyes at the moment on the big picture and getting 2 doses into everybody.
Thank you, Allison. So I'm going to take two further questions. One, I'm going to ask you to speak about myocarditis. That's the first question. And then the second, I'm going to ask David to just speak about the HRM reports we're getting, and then we're going to wrap up. So thank you for your patience. So do you want to go ahead, Allison, to speak just briefly about myocarditis and what we know?
Yeah. So the really quick version about myocarditis is that it's beginning to look real. There's an Israeli report which has been presented and talked about, but if anybody's managed to lay eyes on it, it's not me. Okay. What they are saying is that there's something like 270 cases post-vaccine compared to a base rate of 148 cases pre-vaccine in the same population. So it's not a dramatically increased rate compared to baseline. Myocarditis is more common than you think it is. But in young men, the Israelis have now said that there is something that is between 5 and 25 times the expected population rate. Their estimated risk is somewhere between 1 in 3,000 and 1 in 6,000 in 16 to 25-year-old males, higher in 16 to 19-year-old males than people who are older. Most of their cases are mild, which probably explains why we've had so much difficulty finding it, because, when a 16-year-old complains of chest pain, you do not send them to the hospital immediately, right? You pat them on the head and, feed them, right? Which is what you do with 16-year-old guys always. They're very careful to say that they've had 2 deaths reported, but it's not even clear that cases are myocarditis, which is hard to diagnose, right? Or that they're vaccine related. There does seem to be a signal now in the US military that we don't have much detail on. And as of this week, there's possibly a signal in the canvas vaccine surveillance in Canada. So eyes open, does look like it's maybe something really, next slide, young males, second dose mostly. So not entirely second dose, right? If there's a signal in canvas, that's going to be all first dose because we haven't given much second doses. Generally presents a few days post-vaccine. And I won't go through what to do with it because just go to the CDC website. They've got sort of base information, which basically says chest pain, shortness of breath, palpitations, investigate. If your inflammatory markers, troponin and ECG are negative, you don't have to worry. Otherwise, that's what cardiologists are for. Thank you.
Thank you, Allison. So I'm going to go to our slide on Health Report Manager, and I just want to thank everyone for staying a little bit late. And I think it's just a testament to how compelling, Allison and Peter, your talks have been, and this discussion, that we still have close to 700 people still with us, listening to you. So David, I'm going to turn it over to you to just speak briefly about Health Report Manager, because I know there was a question about that. We're receiving notifications. They don't state the type of vaccine. Is there a way for this to be changed?
For sure. So definitely, we were going to have this slide here without the glitch that happened yesterday. It seemed that yesterday, for whatever reason, people who got Pfizer vaccination, there was a glitch in the HRM notification. Clearly on the back end, we know what vaccine people received. That has been fixed. I actually looked this morning because a patient of mine must have got a really early morning vaccine or it was entered early this morning. So I know that that's been fixed. I do want to highlight the benefits of Health Report Manager. A lot of people, from when I followed up with Ontario MD about this, seem to think that HRM is really just an EFAC service, and it's not. It actually matches the report that's coming in from the site directly to the patient. It saves the secretaries on average about 30 minutes a day of filing time. And obviously there's some safety issues with misfiling that get avoided. But the most important thing right now is that in addition to lists that you'll be getting later this month, of curated lists of your patients that have been vaccinated, you will get notification as soon as your patient's vaccinated by HRM. If you haven't signed up, and many family physicians for one reason or another are not signed up to HRM, it is free. As long as you use a certified EMR in the province, you can email Ontario MD at support@ontariomd.com and ask to find out how to get signed up, not just so you get vaccine reports, but obviously so you get all this other wonderful stuff as well.
Thank you. So thanks, David. I'm going to go to the next slide. Just a reminder that we do have these vaccine modules that have been updated, and we continue to post actually snippets of people's videos from these sessions there as well. Next slide. But of course, we will have the full video recording up onto our website. Usually we have that by Monday, sometimes earlier, and we'll be posting the slides and the Q&A there as well. I just want to say a huge thanks to our panelists today. I mean, we have, I think, something like 130 questions that were posted. 47 of them were answered in the Q&A, including live and many by Liz and David. Others, you know, are some of them are repeats, but those are we'll try and get to in the written documents. I know that people are really grateful, not just for your work here today, Allison and Peter, but for your work overall. So I think there was this really nice comment in the chat from Kimberly Whitgenute that I'm trying to find, because I think, Peter, she gave just such a nice shout out to you about the work. Here it goes. Dr. Juni, Ontarians owe you a huge debt of gratitude. What you bring to the public sphere has given many of us the confidence to carry on. You have been the voice of science and the voice of reason. Thank you. So I think, you know, Kimberly just put it so well there. So thank you for everything that you are doing. And Allison, we are so grateful to you for coming back now for the 4th time. People, you know, we have so many questions and you answer them so clearly and honestly with us in a way that we can be confident that we are as up to date on the science as we can be. So thanks to both of you, particularly thanks to my co-hosts Liz and David for your tireless work answering the questions and helping plan these sessions, and to our team behind the scenes, Olivia Neal, new to the IT part today, and many other people that I won't name right off the bat, but thank you. And thanks to all of you for everything you continually do. We'll see you in 2 weeks.